The following podcast is part of a certified educational activity titled, Do You Know How to Use COVID-19 Monoclonal Antibodies as Pre-Exposure Prophylaxis for Your Post-Transplant Patients? Test your knowledge. Access the entire activity and complete the post-test at peerview.com/EWZ860. Downloadable slides and practice aids are also available.
Hello, everyone. Welcome to this symposium. This will be, do you know how to use COVID-19 monoclonal antibodies as pre-exposure prophylaxis for your post-transplant patients? Test your knowledge. So I am the moderator. I'm Camille Cotton, and I come from, right down the road from Massachusetts General Hospital. I'm here with the panelists Myron Cohen and Shmuel Shoham. And without further ado, I'd like to introduce our first speaker, Dr. Myron Cohen, who is at UNC Chapel Hill and has done a lot of work in the field, and so it's a real pleasure to have him today with us. Thank you.
Thank you. Good morning, or I guess good afternoon. From my point of view, it's so rare to be talking to people live, and you're so used to Zoom, and looking at people is kind of scary. Also, we're wearing a full clothing outfit. Almost, I have not given a lecture with pants on for several years now. So it's kind of a rare privilege. I talk very fast, and I'm just going to make a couple of points about the kind of work we've been doing. And I guess I'll start just by reviewing what you already know, that for COVID, which has been with us for a couple of years now, we needed to understand the rules. We don't know every rule of COVID, but we know that the nose is the route to bad stuff happening, and that once virus infection is established in the nose, if it isn't controlled, the virus can be aspirated to the lungs, can be very inflammatory. People can become very ill, hospitalized, and die. So our goal really has been to prevent infection using three kind of tools: masks, structural intervention; vaccines, which I'm sure everyone in this room has taken and given out; and monoclonal antibodies. Those are our three big strategies. And then lately, we're very focused on treating people early who we believe are at greater risk for progression of disease. Now, the progression of disease idea is really important. You're a very unique audience, because I would guess to say that everyone in this audience is managing people who are at risk of progression of disease. But when we look at the more general population, what's amazing about COVID is how it's selecting age as a metric. And so during the Delta wave, our Alpha wave and our Delta wave, we saw that the people who did poorly and died, that age was a metric that was unbelievably important. And as we go forward, it's going to be tough not to begin thinking about age as something that represents a factor that makes you a compromised host. Being pretty old myself, I'm quite sensitive to that. And then you look at the other cofactors that have been identified, which really don't hold nearly as much weight as age. Those cofactors, I think, go along with age. So I've already told you that our kind of prevention strategies can be structural, like the mask some of you are wearing now, which we know work, or biological. And in the biological space, we've got active immunity. We're not going to talk about that today much, although we might get into a discussion about active immunity. Do vaccines work in everybody, and who can they be predicted to work in? Passive immunity, which we think is extremely important for people who cannot respond to vaccines. And I'm sure we'll use the term today, vaccines and monoclonal antibodies as a way to deal with people who are at grave risk for progression of disease. And then one thing that hasn't worked out for us, so far at least, is treatment as prevention. Now, what do I mean by that? In the HIV field, there's no doubt that our main strategy is to find people infected, treat them, render them no longer viremic, and then they're no longer contagious. But when we tried to do this in COVID by treating a person in a household and showing by treating them early in a household, one way or the other, they don't infect other people in the household, we've been unable to prove the treatment can serve as prevention. And this obviously has a lot to do with the rapid transmission, the R0 of these agents, of the COVID agents. Now I'm going to slow down a lot on the slide, because this is the room where it happens on this one slide. And I really want to make this entirely clear. The way that we're making monoclonal antibodies is derived from work done on HIV for 20 years, and a lot of it is from Michelle Nuzenzweig at Rockefeller and Bill Schief and a few other, and John Mascola at NIH and Dennis Bergen in San Diego. What happens is, for any person with an infection, especially a viral infection, you can bleed them and have convalescent blood. And in that convalescent blood, you can say, I'm going to look for a person whose convalescent blood has super-duper antibodies neutralizing whatever I'm interested in. Today we're interested in COVID, but you could do the same thing with HIV or norovirus or any other infectious viral agent. You find super-duper antibodies in the blood. So a smidgen of the blood plasma or blood serum stops the growth of the virus. But then we have the technology to isolate the B cell that's making that antibody. And once we isolate that B cell, we can make a monoclonal antibody. And so as soon as COVID came along, within weeks, 20, 30 companies were doing what I've just described, trying to find the best antibodies possible. Once you think you have a great antibody, you have to prove that the B cells you've harvested can replicate, can grow in a test tube. Because if you can't make them grow, you're going to have a problem. If they grow well and are producing antibodies well, and you take the antibodies to an animal, and you start asking, if I give those antibodies to a ferret or a Syrian hamster or a monkey, can I either protect the animal from infection or can I treat the animal if they get infected? So there's an animal component. Once we're done with the animal component, we take the antibody into human phase 1 trials, and we look to see they're safe. Now, if they're safe. Here's a really important point. You're all used to watching television, and many of you have given antibodies that are directed against the host. Humira or Keytruda, or one of these antibodies. They have a lot of side effects because they're directed at the host. Monoclonal antibodies directed at viral pathogens have very few side effects. We did a study published about a couple of years ago in the New England Journal where we gave 44,000 people monoclonal antibodies directed against HIV with no serious side effects. So the monoclonal antibodies in the infectious disease field, we're focusing on COVID, but they're a big growth industry. And because we can make them really quickly, and we can make new ones when we need to make new ones. So now, if you look at the development of these antibodies, the NIH collaborated with industry over the last 2 years to develop most of these antibodies with federal tax dollars. And the things we were thinking about are on this slide. If somebody has never been vaccinated or didn't respond to a vaccine, we can offer them immediate protection with a huge dose of an antibody. Donald Trump, who is doing very, very badly, and this, I don't think, what I'm telling you is not a secret, but it's going to be true. He was doing very badly and received 8 grams of REGEN-COV. The therapeutic dose is 1,200 milligrams. So that 8 grams of antibody, I personally think saved his life because a huge amount of antibody was going to organs that were, suffering from SARS-CoV-2 infection. So you can offer immediate protection. You can give them to people who are unlikely to respond to a vaccine or cannot take a vaccine, which is a lot of the patients who are managing in this audience. You can stop the replication of the virus in the nose, and we'll say a little bit more about that in a few minutes. And we do like to inform how much antibody we like to try and understand how much antibody we're putting in different tissue compartments to better understand how a vaccine may or may not work. Vaccines were mostly developed to stop the progression of disease. In fact, we were barely measuring whether they stopped transmission disease. Monoclonals are developed as pre- and post-exposure prophylaxis to stop both acquisition of infection as well as progression of infection. So right away, when we started working on this, who were the target populations? Nursing home patients. Why? Age, and age. And the death rate, 30 or 40% of all the people who died in the United States during the Alpha and Delta waves were living in long-term care facilities, assisted living facilities. Index cases of household. Could we protect other people living in households where, depending on the virus, you go from 10 to 50% household members get infected? Compromised hosts, which we're talking about today, and Dr. Schoen will say a lot more about that. And then, for reasons I won't even explain, we focused a lot on meat packers. And so my colleagues and I talked to every meat packing company known to man. And if there's time, we can go into why meat packers prove so vulnerable. So we did a study with Eli Lilly with a drug called Imdevimab, and the study was called Blaze 2, but this was the first attempt to show that you could take a high-risk person in an epidemic, give them a monoclonal antibody, at that time allowed to be compared to a placebo, and stop the acquisition of SARS-CoV-2. So Lilly built these vans, each one cost about $1 million, and each van had 7 people in it. And they crisscrossed the country with everything they needed to go like a SWAT team to a nursing home. And we made deals with nursing homes that when they had a COVID outbreak, they would call 1-800-HELP, and then this van would show up, and anyone who wanted to participate would randomize to placebo or Imdevimab. And this is, again, against the original strain of virus. And we saw 82% prevention of acquisition of SARS-CoV-2 in the residents of nursing homes by giving Imdevimab. This was proof of concept. Very quickly, the virus escaped this one antibody. So we're not talking about it anymore, but we proved that the idea worked. Now, at the same time, we were working on another drug with Regeneron that's ultimately be called REGEN-COV. And that was used in a slightly different way. It was used both for a household prevention study, where we were able to show that if we prophylaxed people in a household before they were infected, we could prevent infection 80% of the time, the same basic idea. But this is now a treatment study, and I only want to show you one thing on the treatment study. So now REGEN-COV is being used early and to show you that the nose is the window to everything. So once you get SARS-CoV-2 in your nose, it replicates very quickly. That the cycle threshold becomes very low. It takes just a few cycles to see a positive response. So under 20, you got a lot of virus. But the host is going to make antibodies. The normal host, 98% of them, are going to quickly make antibodies, and the viral concentration in the nose is going to fall. Some hosts will be slow in making their antibodies. The hosts who are slow in making antibodies are going to be at greater risk to aspirate the virus from the nose into the lung and suffer the consequences of inflammation and pneumonia that can occur from continually replicating virus. So in this study by David Weinrich in the New England Journal, what he's showing is that now the combination of REGEN-COV to antibodies is simply speeding up the velocity by which the viral concentration is reduced in the nose. If you just look at this slide compared to this slide, he's showing that REGEN-COV does not have much of a benefit in people who've already made antibodies. So the advantage is in people who are slow in making antibodies or don't make antibodies. But those are the patients that you guys are managing, which is why we're here today. At least some of them are those patients. Now, to carry on the story, what happened was we went from the Wuhan virus to Alpha, Beta, Delta, Omicron, B1, B2, B3, B4, B5. So these antibodies, for the most part, had trouble holding up. So everything dropped out of the picture with monoclonal antibodies pretty much simultaneously. REGEN-COV dropped out of the picture, Cilgavimab dropped out of the picture, Imdevimab and its partner, all these companies, they dropped out. Lilly did was said to the FDA, and this is an important idea, they said, look, we cannot do another clinical trial, but we have another antibody called Bebtelovimab, which is active against Omicron. And so if you let us give that to people and show it's safe, and you let us measure its ability to accelerate reduction of virus in the nose, and if you let us use it under EUA, if we prove this to be true, we will go forward with Bebtelovimab. So what happened was they succeeded, and they showed, they did a more complicated study than I'm describing. They did a placebo-controlled trial, and they showed about almost a log difference in velocity of reduction of viral replication of Bebtelovimab versus placebo or other combinations. That led then to the EUA approval of this one monoclonal for treatment to prevent progression of disease in people who are at grave risk of progression of disease. Who are those people? The people who are compromised hostage by our definition, and older patients living in long-term care facilities. So the monoclonal antibodies are really important for COVID and for other infectious diseases. This is going to be an era where we're going to have a lot of monoclonal antibodies. It's not going to go away. However, there's an advantage in pills, in small molecules. And so the directly acting small molecules, low touch, you can drive through, this is President Biden's plan, you do a rapid test, you drive through a pharmacy, they throw the pills in your car and you drive away. That's actually a pretty good idea. As you know, the pharmacists want to be able to do this almost independent of physicians. No effect on if you've been vaccinated or not vaccinated, there's no interaction. But they do depend on patient adherence. These Paxlovid tastes very bad. Patients don't take it, they're not going to benefit from it. Now, the Paxlovid drug has been challenging for reasons that Dr. Cotton already indicated. Molnupiravir is a really interesting drug that had an efficacy in Merck's clinical trial of only 30%. We actually don't completely believe it's as bad as that trial shows. And there's almost as much molnupiravir being prescribed as Paxlovid, which is a shock, because it's only 30% effective. But I think the reason for that has to do with that people afraid of the drug interaction. Conversely, molnupiravir is a big mutagen, so a lot of experts are worried about its mutagenic potential. But I think that either way, and the kind of people that are being discussed today, if for prophylaxis, Dr. Shom's going to get into great detail, if someone gets infected, providing an agent that will stop progression of disease is important. The last thing I just want to say before we end is that a very large number of people with COVID across all populations get long COVID of one sort or another. And I can't tell you, our clinic is managing 1,000 people. There's a study called the Recovery Study that I don't know how many they're enrolling, $500 million study out of New York City to try and better understand long COVID. We know that COVID is shed in the stool for very long periods of time. We don't understand that. Is there still some active replication in some compartment? Is there endless antigenic stimulation inflammation? But one of the issues here is does vaccination, does prevention with a monoclonal, does early treatment affect long COVID? I know no one who can accurately answer that question, but that's a really, really critical question. So this paper is the one that really is a critical paper for our discussion today, a study that demonstrated an 80% prevention of acquisition of infection for 183 days when this combination of monoclonal antibodies were given. Really important observation. Dr. Shom's talking in great detail about this. It led to an EUA that he will discuss again in great detail, the ins and outs of the EUA. And my only last comments are as follows, that resistance is always something we worry about. These monoclonals are growing in people. The virus is trying to escape the monoclonals. So this paper by Jim Crow, who discovered the antibodies that AstraZeneca is using, he demonstrates that the combination retains its activity against Omicron beta 1 and beta 2, probably also against 4 and 5. Again, Dr. Shom will talk about that more. So retaining the activity is a piece of luck, but it's really important for us to have an agent that still works. And then the last thing I'll say before I draw a conclusion is, I'll draw a conclusion just to make it short. So behavior changes are required to limit the spread of SARS-CoV-2. While we're tired of masks really work. And so they're just not going to go away because we want them to go away. And I appreciate that many of you have that in your mind as you're wearing your mask. Vaccines will help limit progression of disease, but they don't work so well. At least the vaccines we have now do not necessarily prevent acquisition of infection, and they're not durable. That's been our biggest problem. Most of you have had 3 or 4 vaccine boosters to stay ahead of the virus. In the fall, we're going to do something different, but we won't go there today. But the point is, vaccines are really important. Monoclonals have been approved through EUA for PrEP, and for the early treatment of SARS-CoV-2. We're waiting to see whether they're going to be officially approved. Remember, the only officially approved drug in your armamentarium now is remdesivir, which has a licensing agreement. All these others are under EUA. Once there's licensing agreements, we have a lot more flexibility in what we do. Antiviral drugs like Paxlovid and others in development, they could be game changers, but they depend on people taking their pills, and they depend on few side effects, the fewest possible side effects. What do we have to do? We've got to improve our vaccination strategy. We've got to ensure availability of simple and rapid tests so people know when they're infected, reliable, simple, rapid tests so we can treat them and that they don't develop progression of disease. We've got to educate patients and healthcare providers about all these drugs and about their use, about pre-exposure prophylaxis, post-exposure prophylaxis, and early treatment. We've not done a good job at this. I mean, we've just not done a great job. We've got to do a better job. And then we've got to match the right people with the right time, with the right medications to try and get ahead of this pandemic. And that's really our goal. So I'm going to turn this over to my colleague, who is going to say everything.
Thanks. So I'm going to start with a case. This is an actual patient of mine, history of acute liver failure due to rhabdomyolysis. As a result, he underwent a liver transplant several years ago. And he was very excited about the vaccines coming, and he got involved in a vaccine trial that my colleagues are doing at Hopkins, and he's received multiple doses. By multiple, I mean 7 doses of the vaccine. And initially, he had good antibodies, but then after a period of time, his antibodies would fall, and then he'd get the vaccine again and bump and fall, and then at some point, it actually stopped going up. And he wants to know, what can he do about pre-exposure prophylaxis? This is an article that just came out the other day, and my sister-in-law sent it to me. It came out of the VA system, and it looked at long COVID outcomes after breakthrough infections. You may have heard about it on NPR. And I think that the top line, which is not a long COVID, but it's obviously a very important outcome, is extremely interesting to me. So if you are an immune-compromised person who, for whatever reason, said, I'm not getting vaccinated, and got COVID at the time when they were doing this study, which was up until, I think, the beginning of Omicron, 6.1% mortality. If you're an immune-compromised patient and said, yes, I'm going to get vaccinated, your mortality was lower, but it wasn't 0, it was 5. And then on the other side is the non-immunocompromised patients, which is not the focus that we're having. Also, in terms of other complications, you can see that getting vaccinated is a good thing, but it doesn't bring you all the way home in terms of prevention. And this is before the availability of post-exposure prophylaxis. And this is one of the reasons why us as clinicians and the patients were so happy that there was going to be post-exposure prophylaxis options, because the numbers that you're seeing for the vaccinated patients with 5% mortality and some of the other numbers were disturbing. The increased risk of outcomes after breakthrough infection in immunocompromised versus non-immunocompromised patients. Many of you guys, particularly the surgeons and the nephrologists, see a lot of patients that aren't immunocompromised, and you can see there's a substantial difference in the transplant patients that you're caring for than in the dialysis patients, which are immunocompromised, but they're not immunocompromised in the way that we often think about. Similarly, a patient with, say, a cholangiocarcinoma or a problem with their pancreas that you may be operating on is very different than the liver transplant patient that you have. And there you see the increased hazard ratio for all kinds of outcomes in the immunocompromised versus non-immunocompromised. Initially, it was interesting in that when COVID first happened, I was expecting our immunocompromised patients to get crushed, and they weren't. And I was happy about that. But I think the reason that they weren't getting crushed is that they were so used to being careful, wearing a mask and all that. And then with enough time, then they got the infection. And just like every other transplant situation, they're like everybody else except more so. So their outcomes are worse. So one of the main option that we have using the term belt and suspenders, so you got your belt, vaccination, and then you have your suspenders, a passive immunotherapy option as a prevention. And so the main suspender that we have is this drug, which is Evusheld. What is it? It's a monoclonal antibody. It's been modified so that it has a ultra long half-life, like weeks and weeks and weeks, so that it can last up to about 6 months. And that's one of the questions that comes up is, okay, you got it 6 months ago. Do we, bring you into the shop and give you another shot, or what do we do? Don't know yet, but that's hopefully we'll get some clarity from the FDA as to what happens with the people that their 6-month clock has run out. So you give it for kids that are over 12 and grown-ups, patients that do not actually have COVID right now, because it's not a treatment, that have moderate or severe immunocompromised conditions, so all the transplant patients, or patients that are not appropriate for vaccination. So in your other life, when you're not dealing with transplant patients, if you have somebody that, for whatever reason, cannot get a vaccine, and by whatever reason, I don't mean that they read in the paper that vaccines cause autism, like a bona fide reason not to get vaccines. So if you got one of those, then they could also get that. It is not a substitute for vaccination. What do you do with it? You give the 300 milligrams of the one drug and the 300 milligrams of the other drug, and you give them as shots in the tushy. And if you give the 150, which is how it was initially, you bring them back in and you give them catch up to get up to the 300. As a monoclonal antibody, it doesn't go through the SIP system, so no worries there. It seems to be, the body seems to break it down through magical pathways that don't involve the kidney or the liver, so no issues there. PK differences don't seem to make a difference. No pregnancy data. Theoretically, the antibodies can go to the fetus. Whether it would do any harm to the fetus, we don't know, but that's kind of where the data is on the drug. So this brings us to the question is what is the vaccine response in solid organ transplants? So the vaccine response in the general population is very good. We know that the vaccine response in dialysis patients is good but not great. So how about the solid organ transplant patients? This is a meta-analysis that included, or a pooled analysis of 29 studies, over 11,000 patients that looked at antibody responses to the mRNA vaccine. 10.4% had a response after one dose, 45% after two doses, and 63% after three doses. I'm sure if we had more arrows for a fourth dose, it would be a little bit better. And I believe that now some patients are getting fifth doses.
Mm-hmm.
And I don't know if the numbers are better after a fifth dose or if it's just that they start dropping down and then it gets them back up to where they were. But that's where we are with fifth doses. So factors associated with poor antibody response, harking back to the earlier older age, that's going to be a big driver. Deceased donor status, not exactly sure what it is about that. Maybe they're on a higher level of immunosuppression. Anti-metabolite use, if my colleague was here who is Cellceptis' enemy, then he'd be very happy to see anti-metabolite use as a bad guy. Recent use of rituximab. Rituximab is really the enemy of getting antibodies produced. Some of the patients that we've had with the longest ongoing infection that they just cannot clear their virus are people that got rituximab, and then people that got rituximab, you can give them a lot of vaccines, they're just not going to get a good response. So that's your group. And then recent use of antithymocyte globulin, and that's another group that has a poor vaccine response. Fourth dose population, they looked at 25 SOT recipients, so the numbers are much smaller than the previous study. Anti-receptor binding domain seropositivity after the fourth dose went up to 84%, from 56 to 84%. Anti-spike antibody increased from 68 to 88%. Neutralization versus Omicron was poor at baseline and did not increase after the fourth dose. So good antibody levels, but how it really plays out in terms of protecting the patient against Omicron, at least in vitro, question marks. And this is data that was put out by Andrew Caraba, and if he's at this meeting, so you can try to corner him and ask him to explain more if you see him. Rising superstar in transplant ID. Risk factors for severe illness. Okay, so first part was showing you how antibody responses aren't great and maybe you're not as protected as you would like the transplant patients to be. But how about, okay, so now they get the infection, what happens to them? And you can see all these different risk groups, including solid organ transplant and stem cell transplant. However, our patients don't just travel as a transplant patient. They're often overweight with a BMI of 25. BMI of 25, that makes me cringe. I'm definitely over 25 myself. I don't always think of myself as in that high-risk group, but I guess I am. And then you can see all the different risks, diabetes, and heart conditions. Oftentimes our patients have all that. All right, so let's talk about this trial. This is a large randomized trial that was touched on a little bit earlier. The population was not vaccinated, not convalescent. That means that they never had the infection before. And almost all were non-immunocompromised. So essentially, these patients are different than the ones that you're using the drug in. We're going to be highly vaccinated group. At most centers, that's now a requirement to get transplanted. And all are going to be immunocompromised. So extrapolation of the data. But what the data did show is that when you gave the drug to 3,400 people compared to placebo, you had decreased rates of infection. 8 out of the over 3,000 participants that got Evusheld, 0.2%, versus 17 of the 1,700 patients that got placebo, which was 1%, got COVID, and the relative risk reduction was 76.7%. What that says is that in a population of non-vaccinated, non-immunocompromised patients, you can all but eliminate the chance of getting COVID by giving this drug, if it's still effective. Right now, it is effective against the viruses that are circulating. What the situation will look like in January, don't know. I'll show you some slides to get you thinking about that. And does this translate to an immunocompromised population? Question not answered by studies yet, but the decision was to take this data and apply it to the highest risk population because the other data that I showed you about how risky it is for a transplant patient to get COVID. And here's a illustration of the study showing how the difference in blue versus red in terms of outcomes, and that there really is a split. Now, one thing that's interesting is that early on, there's already some cases of breakthrough that happen in the Evusheld arm, and then not too many more breakthroughs after the beginning. And what that shows me is that that early on, first couple weeks after you get the shot, you're still at pretty high risk for getting an infection. And maybe the drug hasn't left the tushy yet to get into the whole bloodstream, but maybe people just got it and saying, oh, this is great, I can go to a wedding or bar mitzvah now because I'm protected. But whatever it is, early on, the first few weeks, breakthroughs can occur, and they can occur throughout, even afterwards. And we've all seen breakthroughs of Evusheld, people that got vaccinated, they got Evusheld, they still get an infection. But again, the belt and suspenders to try to reduce the chance of a bad outcome, but not a free ride for now to go out and live a risk-free life. All right, this is a study that also by the super group that are my colleagues. What they did here is they took antibody levels and measured antibody levels and plasma neutralizing activity after getting Evusheld in vaccinated solid organ transplant recipients. 61 patients that were vaccinated. At baseline, they drew their blood. They gave them Evusheld, and then they drew the blood again after 2 weeks. And then they looked at antibody levels at baseline, went up from 424 to 3394. Not a surprise. You gave them antibodies. But what about neutralization? They took their blood. They applied it to an assay that measures how well it neutralizes the virus. For BA1, they went from 8 to 16%. Not so great. For BA2, which is overwhelmingly the circulating Omicron variant that we have now, it went from 7 to 72%. So before they got Evusheld, they weren't really all that protected. After they got Evusheld, they were pretty well protected, not 100%. But that, to me, shows that you can transfer this antibody into their bloodstream and that they will be effective against the virus. Adverse events. We think about this a lot, and we are desperate for additional data. This is the data from the clinical trial, looking at patients that, in terms of outcomes, headache, fatigue, cough, no different between Evusheld and placebo. However, there was this weird thing with the cardiac SAE, severe adverse event, in that it was in 0.6% of the Evusheld recipients and 0.2% of the placebo. We don't know what to do with it. We don't know if this was a thing that, when the numbers are bigger for the post-marketing experience, will go away. But it does make us at least talk to our patients about this risk, and oftentimes talking to a cardiologist if the patient has existing cardiac conditions. We do have the advantage in that anybody that at our center gets a transplant has had a thorough cardiac evaluation ahead of time, so we kind of know where they are in the spectrum cardiac-wise. But it's there. It's disturbing. Do you have any thoughts about this? What are you doing?
I'm not too concerned about this. One of our clinical trialists in cardiology reviewed the data. It doesn't seem like it's really an important signal. And I will say that people who actually, especially immunocompromised patients who get COVID-19, can have major cardiac complications. So for us, I talk to patients about this, but I am very comfortable giving Evusheld in this context. And I think the benefit outweighs the risk. That's my take.
Yeah, I mean, definitely if you remember the slide a few slides ago in terms of the outcome, both for vaccinated and unvaccinated solid organ transplant recipients, the cardiac complications are not, they're not zero. They're up there around 15%. Okay, just a few more slides to wrap up. One sciencey looking slide. This is a good response. This is a bad response. So you take the different monoclonal antibodies and you look at where they are against the virus. So against Delta, for example, Cilgavimab, remember that worked well against Delta and then stopped working against Omicron. And then not shown here is Bebtelovimab. That's going to probably be up here. Good response. The two drugs that make up Evusheld are this one, Tixa, and this one, and they both have good activity against Delta, but one of them still maintains good activity against Omicron, and then when you combine them together, they maintain good activity against Omicron. So still standing, still working against both BA1 and BA2, especially BA2, which is the dominant. I don't have a slide what they'll look like against BA4 and BA5, but probably not as good, which is a worrisome thing if those variants come to our shore in large numbers and replace BA2, how effective will this drug be? So for now, it's effective. Hopefully for the long term, it'll be effective, but don't know. And then this is just another way of showing what I had just mentioned. This is the guidelines from IDSA, CDC, essentially saying what we've talked about. If you have a patient at risk, this is who to give them that. Next slide. And from the NIH guidance, when there's limited resources, so when you have a situation where you're trying to decide about resources, then really try to risk stratify. Thankfully, that problem is going away in this country, and we're having more and more supply and more infrastructure to give the drug. But if you have to limit, this is how to do it. All right, so the barriers, you live the barriers, so I don't know if I need to tell you the barriers, but some of it is supply, although that's going away to a certain extent, and a lot of it is lack of patient awareness, and really our job is to educate the patients that this is out there and available for them. This is particularly acute in groups of patients that are not as tied into the latest that's happening in medicine. So there's groups of patients that really rely on us to educate them, to reach out, to say this is a thing that's available. My sister-in-law, who's a PhD psychologist in Pittsburgh, she's going to be fine because she's the one that sends me the articles. But many of our patients just aren't PhDs. So reaching out to them and developing systems to reach out to them. Now, you've convinced yourself that this is important for your patients, you've spoken with your patients, and now you want to get them the drug. So that's the next question. And one of the ways to do it is to do this therapeutics locator. If you go to this website, it will tell you where to get the different therapeutics, not just this drug, but any therapeutics that are available in the outpatient space for COVID. Outreach to ambulatory patients. I put out an SOS to all my colleagues across the country, and I said, what are you doing? And these are some of the best practices that I learned from across the country. So some people have designated team members that call patients and say, hey, you're eligible, and let's get you in. Some people have developed referral pathways. Some people have put together educational videos, often pharmacist-driven, that patients watch through their portal. Some people take eligible hospitalized patients. So somebody comes in and they're hospitalized for some sort of event that is not the actual transplant. Before they head out the door, they give them a shot. Some places are doing it. You get your transplant, and when you come out the door, you get your Evusheld, some places during hospitalization, there's one of those prompts that tells you, hey, your patient qualifies for Evusheld.
This is a wonderful map. I use this every day. Great.
So this is the strategies to overcome the barrier, the therapeutics locator, and you can really home in, and it can tell you where to get the therapies. All right, next slide. So putting it all together, you are incredibly knowledgeable about the science, about other patients you've dealt with, about the process. The patients are incredibly knowledgeable about their own body and their values. And like everything else that we try to do in medicine, try to bring that together in a way that is effective and that people can make good decisions about how to protect themselves. And this is just a slide that shows that.
Great. And so now we'll hear from a patient. This is a short video. This is Phil Gazzulli and his partner, Nancy. He's a heart transplant patient from Massachusetts General Hospital who's been taking immunosuppression since 2018, and he did receive pre-exposure prophylaxis with monoclonal antibodies. Okay, go ahead and show the video.
Hi, my name is Phil Gazzulli, and I'm a heart transplant recipient.
Hi, I'm Nancy Sarles, and I am the partner caretaker of the heart transplant recipient. So many of the very smallest mundane things in our life change dramatically. Even being around our adorable, always snotty little grandchildren who had a cold, who always have colds, they all of a sudden became a danger point. Like, don't sneeze on Papu, or,
Right.
you know.
I had to be careful.
We had to be just super careful about the littlest things. Everything became a point of attention and possible danger. What did that all incur?
When the pandemic started, I was very concerned. We were in California at the time, actually, when everything, in March of 2020, we were visiting the grandchildren out there, and I was actually feeling pretty good. And the pandemic started, and we flew home in a panic, actually, when they started shutting everything down. So we came home on March 19th of 2020. And unfortunately for me, I ended up having some other medical issues at the time. I had a liver issue, which they still never figured out what caused it, but I ended up spending some time at Mass General. I had a liver tipped procedure, which unfortunately I got sepsis while I was in the hospital. So I ended up I was in the hospital in the spring and summer of 2020, probably for off and on for a period of about 2 months. But I luckily did not catch COVID during that time. This was before vaccinations. So I was extremely, I was isolated in the hospital. So I was lucky and didn't catch it there. And then when I was released, I pretty much isolated for that winter, like everyone else did. We stayed home. We had our groceries delivered for a while to see how that worked.
Cleaned them all off when they came in.
Cleaned them off when they came in. We would, what were the other products? We stocked up on toilet paper like everyone else did. We avoided once the vaccine started. I felt a little better. I was right in line to get one of the first vaccinations when I was available for me. It was in January of 2021. I got my first vaccination, which was a big relief. But we didn't change our habits much. We still stayed in. We didn't go out. We didn't go in crowded places at all. Nobody was dining out anymore. Everything was shut down. So we stayed in most of the time.
And if we did see people even outside, we actually took anyone out of the picture that was not vaccinated. They became not in our sphere.
I saw an article someone posted on Twitter about it. And so I asked the infectious disease department about it, and they said, yes, it will be coming up. But I was not ready for it at that time. It was not available for me. So our lives changed just enough so that like I said, we had that psychological advantage now of just knowing that I did have the most protection that I could possibly have. And so we actually planned a trip and went away for my birthday. We hadn't been away in a couple of years. So our lives have, I'm going to continue, especially right now with this latest surge that's going on. We actually have canceled a couple of things that we were going to do over the last couple of weeks, and some things coming up, just because I've made it this far. This gift that I've been given is very important to me. I wake up every morning and we say what we're grateful for. And my first thing on my list is I'm grateful to my donor. And I feel like I need to honor that. I need to honor my donor and do everything possible to take care of my gift. And so that means I'm going to do everything possible to prevent getting COVID.
That's really lovely to hear from Phil and Nancy. I think many of you have had similar patient experiences. I know that when he got Evusheld, he felt a lot of relief that at least he had the belt and suspenders, as we've mentioned. So why don't I do just a couple of questions. Is Evusheld safe for a transplant patient who is neutropenic and pancytopenic? And I would say yes, and I would say this is exactly who should be getting it. And I actually think we should use it a lot more at discharge. We should be thinking of our highest risk patients. I've actually asked that we give it to all recent or fresh transplant recipients before they leave the hospital. It is such a window of opportunity, and I think we're missing that. And I think especially for bone marrow transplant recipients, other high risk recipients, we should be thinking of it a lot more. So we should really focus our attention on the very high risk people. So after the receipt of Evusheld, how soon can a COVID booster vaccine be given under the, what are the rules on that? Shmuel.
So you want to have, they say you want to have a delay of 2 weeks.
After vaccine.
Excuse me?
After vaccine.
After vaccine, yeah. So I think there's they want the delay of 2 weeks. I'm just not sure how strong the science behind it is, but I think it's to be super careful.
Great. And then what if somebody has recently had infection? What do you think about vaccine and Evusheld? Say they had infection a few weeks ago, they've recovered. What do you recommend for giving an organ transplant recipient? What do you recommend for Evusheld and or vaccine in that scenario?
So is the infection just like a UTI, or is the infection?
No, COVID infection. COVID infection.
Yeah, I don't know how much additional benefit they're really going to get from the Evusheld. It's probably not going to hurt them, but if they've been vaccinated and they got an infection, they probably have tons of antibodies.
Great. Thanks a lot for your attention. We hope this was helpful to all of you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/EWZ860. This activity is supported by an independent educational grant from AstraZeneca LP.